Hi, I'm Danielle Dick. I'm the director of the Rutgers Addiction Research Center, and I am delighted to be here today with Michael Litterer, who is the vice president at RWJBarnabas Health at the Institute for Prevention and Recovery. Michael, welcome, and we are so excited to talk about everything that you're working on. The Institute for Prevention and Recovery, and you and Connie, the leadership there, have been one of my favorite parts of joining Rutgers. So tell us a little bit about what you're doing there at the Institute.
Sure. Thanks so much, Danielle, for having me. I really appreciate it. It's been great working with you. So the Institute for Prevention and Recovery, we are part of the RWJBarnabas Health System, which is the largest academic healthcare system in New Jersey. We serve about 30,000 people a year through various grant-funded programs. There's a wide variety of those programs, mainly focused on substance use disorder. We have a prevention department that does a lot of community-based, evidence-based environmental strategy prevention programs. We are the state's largest funded tobacco cessation program, funded by the New Jersey Department of Health, and we serve about 2,000 patients a year, helping them on their tobacco cessation journey. And then probably the largest part of our program in terms of grant funding and number of patients served is our peer recovery program. So our peer recovery program, we have hospital-based, ambulatory, and community-based peer recovery support teams. Those teams are comprised of NADAC-certified peer recovery specialists, clinical patient navigators, and case managers, and we really help an individual obtain recovery or maintain their journey to recovery.
So that's obviously a wide variety of amazing programs that you all are leading there. So I want to dig in a little bit more to each of them. And let's start at the end there with the peer recovery specialist program, because I know that is one of the things that you all really are known for being a model. And I've been so impressed when I learned about the scope of it. So do you want to talk just a little bit more about what does that actually mean? What are the peer recovery specialists doing? When might a patient or someone who is getting care at RWJBarnabas Health encounter a peer recovery specialist? What does that program look like?
Sure. Many people in the substance use field understand that peer supports is nothing new. Peer supports have been going on for decades and decades in self-help groups, AA, NA, various groups. What's really changed is starting in 2016, identifying the prevalence of individuals with substance use disorder who are coming to our emergency rooms, and identifying that we really did not have a mechanism to truly provide life-saving care, especially in the emergency room setting. So back in 2016, we worked with the state to pilot a new program where we would actually bring peer recovery specialists to the emergency rooms. And the idea is that when a patient comes to our emergency room, and that is any one of our emergency rooms, 24 hours a day, 7 days a week, if that individual has or is suspected of having substance use disorder, they are then connected with a peer recovery specialist. One of the other really interesting and unique aspects is that we have fully integrated our peer recovery specialists into the medical team. So they work hand in hand, shoulder to shoulder with doctors, nurses, medical assistants. Our senior vice president of our emergency and hospital service line, Dr. Chris Freer, actually refers to us as a consult, as a specialty consult, similar to when they call a cardiologist or orthopedic consult. When a patient with substance use disorder comes into the emergency room, they call us as a consult. Within 7 minutes, our peer recovery specialist is bedside to have a conversation with the individual. And that's all we really want to do, is start a conversation, because our services actually go beyond the 4 walls of the hospital and continue for a minimum of 8 weeks after the patient leaves the emergency room. We do extensive follow-up by phone, text message, in person, and again, really gauging the person's readiness. We want to meet them where they're at. And provide that support. When that person needs a little bit more, maybe they want to go to treatment or they need a clinical assessment, our peer recovery specialists refer to a patient navigator. And if the person needs long-term support, they can also access our case management.
That's really amazing. And, I talked previously with Dr. Alexis LaPietra, who I know you work closely with here too, has also come in to really essentially think about how we can make sure that our care throughout the emergency departments is, really a leader in the country. And I love what you all have done in terms of emergency departments are so often places where individuals who have problems with substance use will show up, right? Intoxicated individuals or individuals now who've overdosed. And very often, those individuals were kind of patched up. They were treated for the acute problem, and then they were sent back home. And so the fact that you all have really been at the forefront of actually, this is someone who potentially has a life-threatening disease. And this is our opportunity to intervene and to help get them the support that they need. And the fact that you all have implemented that throughout the hospital system, I just really want to pat you on the back because I know that you won't do it, but to let everyone know that this is really amazing in terms of leading the way of how we need to be addressing substance use disorders in this country. So thank you for all the work that you do on that front.
Yeah, no, thank you. And I think it's interesting the evolution of our program. When we were first funded, we were only able to serve patients who had been naloxone reversed. So we were only able to serve patients who had just overdosed and had been revived and brought to the emergency room. Today, that looks very differently for us. So we see about 800,000 patients a year in all of our emergency rooms across the system. And we have now implemented standardized screening for all patients. So we are not waiting for patients to overdose or be in their most acute phase of their substance use disorder. We've actually been fortunate enough to have the capacity to address that much earlier. So we're asking every single patient, if you're coming with a broken finger or chest pain or whatever it is, we are asking every single patient 4 questions around their substance use disorder to, again, better try to identify before it becomes more acute. Because, in our harm reduction strategies and really our best practice, we want to meet people where they are at, but it's much easier to meet someone early on in the process than waiting till it gets to that acuity. So we're really fortunate to have that 24/7 staffing capacity where we can really look to help identify and serve all patients with substance use disorder, no matter where they are in their journey.
Yeah, absolutely. And, when Dr. LaPietra was here and we were talking, she was talking about the fact that, if we're looking at people who, for example, have had a heart attack or might be at risk of that, there's a variety of things they probably need to do: medications, exercise and lifestyle modifications, as well as diet modifications. And not everybody's ready to do all of those things all at once. And we understand that that's a process of figuring out how you're going to, implement some of those things. And so the fact that we are now applying those best practices to substance use disorders too, in terms of thinking about what are the things that the individual is ready to do to start managing this disease, and what are the things that maybe they're not ready to do, but the supports are there when they are ready to implement kind of the next step, is one of the things that I think is so amazing about the really continuum of care that the peer recovery specialists are providing to individuals who've come through our emergency departments and for whom might be having problems associated with their substance use.
Yeah, no, I appreciate that. The other big thing that we're proud of is that we decided at the beginning of our program, we were not going to be solely an abstinence-based recovery program. We really want to take a holistic approach and really look at the whole person. So the other thing too is we've also standardized our social determinants of health screening. So not only are we screening all of our patients for substance use related issues directly, but we're also screening them for job, housing instability, food insecurity, transportation, interpersonal violence, all the different other determinants that really we know drive about 80% of an individual's overall wellness. So we not only screen them, but we also actively engage the patient for those whatever services they may need, and connect them to those resources. Because as you said, someone may not be ready to deal with their substance use disorder directly yet, but maybe they're housing insecure, or maybe they don't have ready access to food. We can work with them on those basic needs and really chip away at all of these things, because we know substance disorder is a very complex issue, but we're really proud of the social determinant work we do as well.
Yeah, it's amazing. And I know that you also have a new program in the works that is taking peer recovery specialists into OBGYN care too. So do you want to talk a little bit about that?
Yeah, we're really, really proud of that. So we've worked with Suzanne Spurnell, who is the Senior Vice President of Women's Services for our healthcare system for many years. And we've really talked about the unique needs of a pregnant mom or recently delivered mom who may have substance use disorder. Very, very just unique needs. And so we were fortunate enough to apply for a grant. We're one of only 2 organizations in the country to receive this funding. It really focuses on reducing deaths related to substance use disorder among the maternal health population. And one of the other really innovative things we've done is, we really have always looked at a recovery specialist very similar to a community health worker. We've just said at times a recovery specialist is a specialized community health worker, just focused on substance use disorder. We've also looked at other non-clinical roles within healthcare, and one of those is a doula. So we took the opportunity for this grant to actually cross-train a team of recovery specialists, but also as doulas. So that recovery specialist, one, they come to the job with their own lived experience. They then became trained as NADAC certified recovery specialists, as well as certified doulas. So now they can really, really go through the journey of recovery, but also childbirth with the patient that they're serving. So they serve that dual purpose, but again, taking that approach, that whole person patient-centered approach, having those dual certifications really help equip them to be quite an ally to that individual through a very scary and tough process.
Absolutely. And one of the things that I didn't fully appreciate until I started talking to OBGYN doctors and individuals who are working in the space of, essentially trying to treat pregnant mothers who may have substance use disorders is the impossible position that they get put into, in the sense of, when you're not at a place like RWJBarnabas Health and necessarily are getting best practice care, that in fact, you could have this horrible decision of, if I disclose my substance use to my provider, am I now at risk of, being judged or treated differently, or worst case scenario, losing my child or maybe my existing children? And so really, I think to be thinking about how we provide compassionate best practice care for women who want to do the best for their baby and their current and future children, to really get treatment, and to introduce all of that to, like in the emergency departments, a place where they're coming in for care is, I think, so important, and such an exciting new direction that we're seeing in terms of treatment of substance use disorder.
Yeah, it's really exciting. And, one of the things that unfortunately we continue to battle against is stigma. There's such tremendous stigma associated with substance use disorder. And, that's one of the great things of having Dr. Alexis LaPietra on the team, is because, listen, substance use disorder is a chronic medical disease, and it has been identified as such for a very long time. But unfortunately, many people in healthcare see it differently. They see it as something different or separate. So to have not only a doctor on the team to be able to speak, peer to peer with our doctors and explain the disease of addiction and the condition of substance use disorder, but also to really reduce that stigma. I often use the comparison between substance use and diabetes. And I think for the maternal health population, it's a great example. If a mom comes in to a doctor's office with gestational diabetes, they treat that, right? They don't judge the mother for what her eating habits are. They say, okay, we have a lab test that shows this mother has, an issue with balancing her blood sugar. We need to intervene medically. We need to also train her on what to eat, what not to eat, to help support that condition and support the healthy development of the baby. Same thing for substance use disorder. If we don't judge someone for poor eating habits related to diabetes, we shouldn't be judging them for their substance use disorder, whatever that may be. So I think there's some work to do in the medical community, but also the general public to really understand substance use disorder as the medical condition that it is.
And, you know, it's important, I think, to think about the context in which really our understanding of substance use disorder and other psychiatric conditions has changed so radically over the last few decades. And so I'm reminded that my first research advisor, who was Irv Gottesman, who was kind of one of the fathers of the genetics of schizophrenia. He did some of the first studies to show in twins and adoption studies that that schizophrenia, I mean, here this severe psychiatric disorder was genetically influenced. And he used to talk to me when I was an undergrad, just starting out research in this area, about how when he was in grad school and he was talking about the idea that there were genetic influences on things like substance use disorder and mental health and behavior, that people thought that was ridiculous, right? They were like laughing at him because everybody knew that that was all environmental, right? Substance use disorders where you were making poor choices and you had poor examples in your families. You know, mothers were blamed for everything, right? For children who had autism, for children who had schizophrenia. We thought it was really all environmental because we could see these things running in families and thought, well, it must be poor parenting, poor environments. And of course, what we've really found over the last several decades is there's strong genetic components to it. It's complicated because it's both genetics and the environment, all the things you were talking about, like environments found in our families, our communities, our neighborhoods, et cetera, and how it all comes together. And so I think that our ability to integrate all that new knowledge, and then as we've learned more about the biology, new medications, et cetera, you know, that just hasn't been integrated into our medical care systems as quickly as we might like. And so, you know, it's really exciting. And of course, one of the reasons I decided to come to Rutgers and lead the Rutgers Addiction Research Center here is to partner with clinical partners who are doing best practice, and then think about how can we create these bi-directional pipelines between researchers learning from your experience in medicine and clinical practice, kind of on the front lines, and then you all essentially having the ability to work with us on here's what we're learning on the research front and how can we use that to improve clinical care and practice. So that's one of the things that I think is really exciting about what's going on here at Rutgers between the research side of things and the Institute for Prevention and Recovery.
You know, Danielle, it's funny. I remember this was years ago, sitting in a room with one of our executive leaders from the system, and he said, you know, and he was speaking to a whole group of our staff, most of them recovery specialists, and he said, you know, you are the most passionate group I've ever met. I've never met a group so passionate and so committed to helping people. Why do you think that is? And someone spoke up and said, one of the main principles of recovery is you have to support others in order to strengthen your own recovery. That individuals in recovery see themselves as obligated to help others in order to help themselves. And what I think is interesting is that we've really tried to carry that philosophy into our partnerships and our work. And you can relate that very much to research. We are so committed to helping others either learn from our lessons or learn from other lessons. You know, you sort of have to give it to get it. And I think we said this to you when you first started. We were so thrilled to have you because we're an open book. We love to hear what's working and what's not working. We probably actually like to hear what's not working a little bit more than what's working. And that can only be done when you have the capacity to do true research, to truly study what you're working on. And listen, I think we have a really robust data set to pull from. So all of our work is done in our electronic health record through Epic. So everything we're doing is being documented, and the possibility of pulling reports and data and then doing interviews with our staff and the medical staff, it almost feels endless with the possibilities. But again, I think it all relates back to this principle that we are only going to truly help people if we can help other people help people. And the best way we know to do that is to do research, to publish that research. We have a team that reads the most recently published research on a daily basis. And the first thing we think about is, wow, would that work for us? How does that apply to what we're doing? And we hope to have more and more of an opportunity working with you in partnership to get the word out, to, again, just help more people help people.
Well, hopefully that will be inspirational to all the RARC researchers who hear this and can, get their wheels turning about all the exciting places that we can potentially work together. So I want to switch gears for just a second. We've talked a lot about the center and all of the programming that you're leading. I want to talk more about you. How did you end up in this field and in this leadership position at the Institute for Prevention and Recovery?
So that's a much longer story, but I'll give you the extremely abridged version. I decided early on, most of my family was in the medical field, and I decided I was going to go to nursing school. I went to nursing school and I kept on waiting to like it, and I never did. Nursing was just not for me. While I was doing that, I was actually working at a small community-based organization doing substance use prevention work with no intention of actually doing that work. Just it was a job in high school to, sort of give myself a little spending money. And before I knew it, I was in my early 20s. I was finishing school and I said, wait, I don't like what I'm doing in school, but I love what I'm doing in my job. And so I just ended up staying, working. And about 7 years ago, I had worked with Connie Green for many years prior to that. And we had a conversation. She said, I'd love to have you on the team. And I originally said, I don't know. But I did. I joined the team. When I first started, we had about 15 staff, and our budget was about $3 million. We're now up to 230 staff, and our budget's about $23.5 million. So we've grown tremendously, and I haven't looked back since. But I sort of, I don't know, organically came into the field, but thankfully at an early age found out I loved it and really stayed committed to it.
And of course, I feel the need to also mention for all those who don't know and are out there that, Michael, you had both, I guess, probably genetic and environmental influences on your interest in prevention, since your mother is also a leader in this field in New Jersey as well, too.
Yeah, and I think that was also by happenstance as well. So probably a good research study to see if it was genetics, environmental, a little bit of both. But yeah, I've been fortunate, and I love what I do. I love it.
So maybe we could end by talking about the prevention side of things, because you mentioned that there's also prevention programming that the Institute for Prevention and Recovery supports. We talked a lot about the peer recovery supports. You mentioned some of the tobacco cessation programs. Are there other prevention programs that are ongoing that you want to highlight?
Yeah, the Institute for Prevention and Recovery has been in business for over 30 years. And really for 23 or so of those years, we only focused on prevention. So we are really proud. We have very long-standing substance use prevention programs throughout New Jersey. We have some environmental-based programs that take a coalition approach. So we have multiple coalitions in various parts of the state where we look to change policy, engage key stakeholders, and really work with the various sectors of the community to not only drive but inform substance use disorder needs and prevention. We really help facilitate the opportunity to do best practices in that area. The other thing too is we're also very excited. We have a program called Communities That Care. So Communities That Care is actually done all across the world. We're the only ones implementing that in New Jersey. And what's interesting about that is that we have a real diverse group of communities that we're working with. So we're implementing the Communities That Care model in the South Ward of Newark, in Long Branch, in Toms River, and in Barnegat. So anyone who's familiar with New Jersey, there's real diversity in the size of those communities, the demographics of the communities, the geographic area within the state those are located. So it's really been interesting to see how you're able to implement an evidence-based, very structured program, but very individualized for the communities and their specific needs. So we're very proud of the prevention work that we do. And when you look at the environmental strategy approach that we do, our work impacts hundreds and hundreds of thousands of residents every year through our policy and environmental work.
Yeah, it's amazing. And I wanted to make sure we highlighted that so that researchers that are out there that maybe do more community engaged work or are on the prevention side are also aware that there might be opportunities to partner with you all and think about that. I know you and I have talked about some of my own personal work on personalized prevention and ways we might work together to try and study that in New Jersey too. So I think there's a lot of opportunities for partnership with your team and really with just the wide array of programs that you lead. So thank you so much for being a wonderful partner. Is there anything that we didn't get to today that you want to highlight for all of the RARC researchers out there?
I think the one other thing that I would highlight, and probably actually the most relevant to this conversation, is we are really proud. We have a research and evaluation team, a data analytics team. So I think for this purpose, we are such a great partner because we have a team of 8 highly skilled, multidisciplinary, multimodal. I mean, they do everything. They do qualitative, quantitative, and we really serve as a great partner in collecting that data, cleaning it up, partnering with researchers because we have that internal infrastructure as well. And I don't think we'd be anywhere without them in terms of research, grant writing. They're really an essential part, and I think a really great asset to partnerships like this.
Absolutely. I'm so glad that you pointed it out. And like you are also fabulous people to work with. I can attest to that. And so thank you so much for your time, Michael. I really appreciate your partnership, all of the amazing programs that you're leading there at the Institute for Prevention and Recovery. And I look forward to seeing where our collaborations go over the years to come.
I'm very excited, and thank you so much for having me.